this session is being recorded, and it'll be available on our YouTube after this. So Sam, if you could introduce yourself and we can get started.
Sure. Well, hi everyone. My name is Sam. As Ethan was saying, I'm an intensive care specialist working in Nepean. I've got a real interest in using Echo to help look after critically ill patients, and I find it an incredibly useful resource. And what I'd love to do today is try and talk to you about how I can use it in patients who have shock. Um, I hope I'm pitching this right. Please interrupt me at any time if you've got any questions or thoughts. Um, I have not worked in resource limited settings a lot. I've taught on a course out in Vanuatu. I've done a lot of teaching sort of online to guys in Vanuatu and things, but I'd love to know more. So as I'm talking, if you think that you can help educate me on how things are going, that would be amazing as well. And yeah, feedback's great. And tell me if you'd like something more about this, more advanced, or anything in the future, just let me know, okay? So I'm going to talk for about, I don't know, 30, 40 minutes, maybe some time for questions afterwards. And I'm just going to show you how I think we should be using sort of point of care ultrasound with echo to try and help recognize sort of shock patterns. And then the next bit is it gets harder as we go along, because what I'm trying to show you here is to picking up all the signs you possibly can with point of care ultrasound and then learning how to integrate that into the clinical setting. And I describe that as a way to like personalize your therapy in shock. I'm probably not going to say anything that's revolutionary in here, but I guess I'm going to try and give you a framework that I use in my day-to-day practice on how I sort of put everything together. Because I sometimes find that patients don't read the textbooks, and it's often not as easy as it's meant to be sometimes. And I'll show you some examples of that. I'm going to be using some of my own images, but mostly I'm going to be using ones from the trainees that we've been looking at on the Pearls butterfly coaching app. So I'm hoping I'm going to use lots of images that I've got from some of you guys and try and use it and to say what the little bit more information that maybe we can get out of point of care ultrasound echoes. Um, I want to try and also push you a little bit if I can. We're going to talk a little bit on some of the more advanced stuff. And for those of you who are just using sort of 2D ultrasound, we're going to talk and making sure you get everything you can out of that, but also showing you to that next stage. And I think probably the next stage of 2D is looking at regional wall motion abnormality assessment. And I'll talk about sort of a framework you can use for that. And then maybe we touch on some color Doppler and pulse wave Doppler things that if you've got machines that have those capabilities, you can start branching out into that. So let's start with the case. So this was a case from Vanuatu, a 48-year-old man with end-stage kidney disease. He's not on dialysis. And he was found at home and he was unresponsive, hypotensive, hypoglycemic, hyperkalemic, and acidotic. So super sick. Okay. And this was the first image that was brought up when someone did a point of care ultrasound after assessing him. And this guy was obviously in shock. And maybe I'm not going to interpret it just yet. I'm just going to take you through the images, let you have a look at them. So this is the parasternal long axis view. And for those who are just starting, we've got the right ventricle on the top, left ventricle down here. There's the left atrium, and then the aortic valve and the mitral valve. You got the pericardium as that bright white bit behind it, and then there's a lung you can see behind it. And maybe in the lung, we can start to see a little bit of a black shadow that comes down through here. That might represent a pleural effusion, and we've got these bright white lines that are coming down. Then you can rotate your probe around 90 degrees, so the marker's pointing towards your left shoulder after that. And here we can go with our short axis view, where you've got that left ventricle, looks like a donut. And then if you just fan down a little bit more, you can see the mitral valve here, but as you fan down, we see the mid-papillary muscle level. And again, you've got that left ventricle sitting in the middle and then the right ventricle sitting in around it. And one of the things I'm going to ask you to have a look at is just look at that interventricular septum on that view. We've got about a 5-second clip. And when that patient's breathing, it looks like some of that interventricular septum sort of push gets a little bit worse. And it particularly looks like it happens during diastole. And the way I'm looking at that is I look at how that ventricle contracts, and it's when that ventricle relaxes that you seem to get that pressing effect from that interventricular septum. Okay, then we've moved on to the apical view here on the left. So we're aiming to get that interventricular septum down the middle of the screen. We've got our left ventricle over here on the right side of the image, and then your right ventricle's over here on the left side of the image. And I know it's your right over here is because the tricuspid valve, the annular plane, sits a little bit higher than the mitral annular plane. All right, so I know that's the right ventricle. Now, the right ventricle is meant to be about 60% the size of the left ventricle, and this isn't. This looks a bit bigger. We've got to be careful. I think we're off axis a little bit. You can see how the heart looks like a soccer ball. It's meant to look long and thin like an almond or like a rugby ball. And that's where we've got to be careful that we don't rely on one image alone, because this can overestimate the size of the right ventricle if we do it just in the apical four-chamber view. Okay, but even with that, we can see that this RV still looks big, and this function is not right. Normally, that right ventricle should be coming all the way in, moving much more in there, and that bellows function, and that right ventricle is not moving well at all. Okay. Next part we can see here is this subcostal view. We're actually probably rotated around the wrong way. We've got to get that marker pointing towards the left side of the patient, because normally you have the right ventricle on the other side of the image, but it's okay. We still can see we've still got some good images though, because what's interesting in this one is this sort of black worm that's coming in from the right side. That is the IVC, the inferior vena cava, and it's dilated, right? And it's big and plethoric, as we call it. Okay, now what the person who took these great pictures, they said that they felt there was severe LV dysfunction. The patient didn't respond to 500 mils of fluids, and they were started on vasopressors. And I think that's brilliant. But what I'm going to try and tell you in a second after we've talked about it a little bit is how we can tease out just a little bit more. Okay. So we're going to talk about shock. Shock is that supply-demand mismatch that we see in critically ill patients when they get things like septic shock, right? The body wants lots and lots of nutrients. It needs to get rid of all this waste product, and it's got this huge demand, and the body simply can have difficulty trying to deliver that. What that can do is that can lead to cellular necrosis or cellular dysfunction. And if you don't catch that early enough, that can cause irreversible cell breakdown and even go towards multi-organ failure and death. So what echo is going to help us try and do is pick out some of these cardiovascular changes, because cardiovascular changes like low blood pressure and poor microcirculatory flow are absolutely sort of ubiquitous across shock. But we're going to use echo to help us manage it. And what we're going to use echo for is to try and pick up these patients early. And that's what the key is with caring for sick patients, is that you've got to pick up shock early. And then you've got to try and find that reversibility and what you can do to optimize cardiovascular performance and try and pull that patient back from when it's not just compensated shock with that high heart rate and peripheral vasoconstriction and all those things that the body does to try and maintain flow through the body. It's when it starts decompensating and the stress outweighs the physiological reserve, and that patient sort of falls off the waterfall. And that's when we can't get them back. Okay. And that's what we're going to try and work through in these next ones. Okay. So as I start off thinking about the shock, well, as we're all taught at medical school, there are kind of these four classic sort of ways that shock is described as being hypovolemic. It can be obstructive, like with PE or tamponade or LVOT obstruction. It can be cardiogenic from a terrible heart function, or it can be distributive, like vasoplegia from shock. And all I can say is that I sometimes find that that's a little bit simplistic. And sometimes we're seeing two of these things can be at play. And often we have sort of competing interests at any one time. And that's how we're going to use echo to try and help personalize this therapy. Okay. So before we go through how echo is going to do that, remember, we need to just, first and foremost, we need to think about two things. First of all, we've got to get source control, because we're going to use echo to try and improve our cardiovascular performance. But if we haven't, if we've got an abscess that's somewhere as a source of infection, all the hemodynamic optimization in the world is not going to prevent that patient from deteriorating. We must get source control. We've got to make sure if there is a bit of dead gut that's sitting in the tummy, that we've got an operation that takes out that piece of dead gut. or if we've got someone who's got obstruction from a PE or tamponade, we've got to get rid of those causes of obstruction before we can try and optimize cardiovascular status first. Okay. So often we talk about having a good history and examination. We're doing that in the same phase as trying to decide on management and the complexity of the patient. Okay. The next part about optimizing therapy, is this idea that we can't just focus on a blood pressure and we can't just focus on everyone getting 20 to 30 mils of fluid. I'm sure we've seen the guidelines there are that this is important, and we aim for mean arterial pressures of 65. And I'm not for a moment suggesting that's not important. It's just not the whole story. And this has been beautifully demonstrated in this study from the Spanish Society of Anesthesiology, where they did this massive multi-center study in like 1,500 patients, and they divided them up between standard of care and this kind of personalized shock therapy where they used echo. They actually just used echo just for mainly left ventricle function assessments. And I think it's more than that, as I'll show you. But they used clinical examination in terms of cap refill, as well as using echo to help guide therapy. And they found that there was a difference in mortality. There was a difference in time for patients getting off catecholamines earlier and getting off sort of vital support like mechanical ventilation earlier compared to usual care. And again, this sort of highlights this idea that personalized medicine towards our patients has benefit. This study is not perfect, but it is a beautiful study that just reminds us we do the simple things well. We've got to examine our patient. We can't rely on a single parameter by itself. Unfortunately, our patients are much more complicated than that. And we need to use echo to help guide the hemodynamic profiles. So this is kind of the way I try and keep it simple in my head. Again, beautiful paper by a guy called Philip Rolla from Canada. And he just wrote this really nice way of thinking about it that I hope he doesn't mind me using because I think it explains it really well. So when we're personalizing our shock management, we need to think about kind of 4 phases of the cardiovascular system. The first one is going to be is how is that left ventricle interacting with your arterial system? All right. If you've got LV that's absolutely hyperdynamic because the patient's so vasoplegic, that's a left ventricle desperately trying to keep up with that vasoplegia. If that ventricle then suddenly stops working and you've got vasoplegia and you miss the fact that that left ventricle is then failing and you've got this vasoplegic system, you're going to get uncoupling of this left ventricle arterial system, and that is going to cause a massive catastrophic collapse in that patient's cardiovascular system. So you've got to keep an eye on what that left ventricle is doing and how it's talking to your arterial system. Next phase is thinking about the macro to micro circulation. I'll use the example, if you give a patient too much vasopressor and you just keep on giving them more and more and more noradrenaline, trying to keep their mean arterial pressure up above 65, you can cause excessive vasoconstriction. And that means that you don't get nice flow going into your capillaries and into your end organs, and you will get end organ hypoperfusion, and you can get things like kidney injury and liver dysfunction. Okay, so you've got to make sure you don't squeeze a patient too much. And then the next part is to think about the venous system. And this is something we often forget, that you need to have blood flow from the capillaries into the venous system to allow flow to get around your body. If you've got lots of signs of congestion from things like fluid overload, where you get dilated IVCs, raised right atrial pressure, particularly if you're seeing it with right ventricle dysfunction, you do not want to be giving fluids to these patients. These patients will be fluid intolerant. And so you've just got to make sure we don't give our patients too much fluid. And that's how we're going to individualize our therapy. And I'll show you a few tricks. And then the last part is thinking about the right heart. We're terrible at recognizing right hearts sometimes over here in Australia. And we've got lots of evidence to say that when we miss it, it's not good. So we've got to keep an idea on how that right heart is interacting with that pulmonary system. And so we just make sure we don't miss dilated right ventricles and badly functioning right ventricles, because again, they need support just side the left side of the heart. So kind of 4 sort of section model, thinking about the LV arterial coupling, thinking about the macro to micro circulation. I think about my venous system, making sure it's not congested and my patient isn't fluid intolerant. And I think about the right ventricle. Okay. And this way we can start targeting our therapy. So let's start off how I sort of think about this first of all. So with my patient, as I approach them and they're in shock, first thing after we've made sure no source control is done and we make sure that we've got no obstruction, then I'm going to start thinking about, do they need fluid? And we got two little things to think about. First is that patient fluid responsive? And the second thing is are they fluid tolerant? Can they tolerate fluid? And sometimes you can get a bit of both. And that's where we've got to repeat what we're doing. We're going to try and give them a little bit of something, and then we're going to reassess. And you can do that both clinically and with echo. Okay. We can then start looking at our left ventricle size and function to help with that. We can look at our micro to macro circulation things by looking at capillary refill, looking at our lactate. I know that's not always easy to get in the Pacific Islands, but if you can get a lactate, we use it here to kind of guide therapy. For the venous congestion, I can look at my IVC. Okay. If we can use some of the more advanced measures a little bit later, looking at things like tricuspid regurgitation and venous excess, looking at flows in the hepatic and portal vein, but I might leave that for another day. And then finally, we look at our RV size and function. And I'll show you some examples of all of this. So let's go back and talk about our patient that we looked at right at the beginning, and we're going to tease out a little bit more based on that framework. So first of all, this patient was on some vasopressors and they've been given a little bit of fluid but didn't respond to the fluid. Now let's take an idea about the vasopressors first of all. So he was put on vasopressors, this patient, because he was in shock and the blood pressure didn't respond when they gave him fluids. That's absolutely right. But one of the things we can see is, first of all, let's look at this left ventricle and we'll think about that way that the left ventricle is going to interact with our blood pressure. Now that left ventricle is not working well at all. That is a dilated ventricle. You can see here, I can count the centimeters, and this looks to be about 6 centimeters wide. So that's a dilated left ventricle, and it's not contracting normally, and that is severe dysfunction. If we give this patient too much of the catecholamines like noradrenaline and vasopressors, that can increase up the afterload, and that can make it even harder for that ventricle that is failing to be able to cope with that. So we've got a dilated left ventricle, which is not functioning well at all. So we've got to make sure that we don't give them too much of the vasopressor. And the way that we're going to assess that is that we give a patient some and then we reassess. And if the ventricle looks like it's doing worse, we know that we're heading in the wrong direction and we need to try something else. And what I'd be using here, if I can, is I'd be using an inotrope. I'd be looking to try and get out something like adrenaline. We're lucky in Australia, we've also got options on where we can try things like dobutamine and milrinone, but I know those are hard to get sometimes in the Pacific Islands. But if you've got adrenaline might be useful because it's got more of that beta effect and it's going to help contract that left ventricle more. And let's think about the fluids next. So is this patient going to be fluid responsive? Well, can you see all these lines that are behind the heart? We might want to think that these are signs of what's known as B lines. And B lines can happen when you've got pulmonary congestion. Okay, that's what these arrows are pointing at. Now, if you've got a raised left atrial pressure and you get lots of sort of backflow issues going into the lungs, you can get these B lines. Now, B lines happen. I'll just show you. This is another example of all these kind of comet tail artifacts that can come from the pleural space, or in this case, it's from the pericardium. And these happen because if you look to the top right of the screen where this ultrasound is resting on the skin, that red line is a cartoon just for that pleural line, the visceral and parietal pleura rubbing against each other. And here's an alveolus. Now, if that alveolus is normally it's just filled with air, right? But if you get a bit of fluid into it, that ultrasound waves it bounces off the gas fluid interface. But some of that will stay within that space. And so all these little sound waves just get bounced around all over the shop and they all come sort of back at different times up towards the ultrasound probe. And so you get these kind of continuous comet tail artifacts that come all the way down from the pleura or from the pericardium in that last image all the way down. Now that means we've just got lots of fluid in the interstitial space. There are things that can cause that, like sometimes pneumonias or a viral infection can cause those. But most of the time, it's going to be things like raised left atrial pressure and having too much fluid in the lungs. And I think that's what we might have been doing to this patient, is pushing him potentially into a bit of pulmonary edema. Okay. So the next thing we can look at is we can see here with this big right heart that's not functioning well in this massively dilated IVC it's another sign to start saying that we've got some venous congestion going on. And what that means is, again, if we put more fluid into this system, it's going to make that congestion worse. And that's going to make that sort of capillary to venous interface even worse. And so we've got to be really careful that this guy does not need any more fluids. This patient needs some vasopressors and inotropes if we can give it to him, and make sure we've obviously giving him antibiotics to try and help with the sepsis that he might have. Okay. The final part was looking at the right ventricle. The right ventricle, the way we try and protect that is we try and avoid putting more pressure onto it. And we can avoid that by making sure that we keep the oxygen levels up, the carbon dioxide levels down. We try and correct the acidosis, maybe with some bicarb, sometimes with dialysis. And if we have to put them on mechanical ventilation, we can try and make their respirate and tidal volumes bigger. But we've got to remember, we've got to be really careful with ventilation in this patient, because if you put them on a machine which increases up the RV afterload, that might also be bad. So it's a really delicate balance where we can try things a little bit at a time and then reassess. And that's the important part, is trying to reassess when we're trying something and repeating our assessment and constantly coming back and assessing each of those parts of the cardiovascular system. Okay. So maybe if we just take a pause for a minute and just think about learning points so far, that the big one for me is that echo becomes, or point of care ultrasounds, a bit of an extension of examination. We need to try and get accurate imaging as best we can, which takes about maybe 10 to 20, maybe 30 scans. After you've done it with a little bit of teaching, most people have normally got it at that stage. And I promise it's not super hard to do. But we do our sort of 10 to 30 studies, and then we're going to hopefully know that we're doing accurate imaging. The next thing we're going to have to do is make sure that we're interpreting those images appropriately. And again, that takes a little bit of practice. And the better you get, the faster you can do it, and you can start doing it as you're doing the imaging. And then the last part, which is the most tricky bit, is then trying to take those findings that you've got and put them into managing that patient. And as I was showing in that last case, I hope just thinking about that framework of, the left ventricle arterial system, that microcirculatory system, the venous congestion in the right heart, it gives you a systematic framework that you can start working on figuring out what you're trying to optimize and what you're making sure that you're treating and not making worse. So a few tips and tricks on how to get this right. So the first thing is let's talk about accurate imaging. So to get accurate imaging, I talk about wanting to be on axis. And I'll show you some of these little cartoons I've been doing with the artificial simulator that we've got. I do little bits of fanning to try and make sure in my parasternal long axis view that I make that left ventricle look as big as possible. I don't want to be off to one side, or I call it sort of, being off the gun barrel, so to speak. So if you're off to one side, you can underestimate the size of the left ventricle. We've got a three-dimensional structure. You've got a two-dimensional imaging tool. You've got to fan through the structure. Okay. I can do little bits of rotation, trying to make sure that we are making that left ventricle look as long as possible in that parasternal long axis view. And it's little movements. So little bits of rotation, little bits of fanning, make that left ventricle look as big as possible and as long as possible. And once you've done that, that's when we can press record, and that's when we can review the images. A key point for me is trying to take your time if you can, and look at all the images when you finished. So hopefully you don't, for these point of care ultrasound studies, you don't have to take a huge number of images. It's normally only maybe 5 to 8 images is all you need. But go back and have a look at each of them. And as you see them loop, it often helps you make an interpretation. The other thing is, remember I said that if you're off axis in some of the images, you can make things like the right ventricle look artificially large. If you have your time to go through each of the images, you have less of a chance of making mistakes. So don't make a call on one view alone. Try and review all your images. You normally find that one of the echo windows you can't get in a critically ill patient. That's just sometimes the way it goes. But if you can try and look at all the images you can get, and then you make your interpretation, hopefully that helps. When it comes to interpretation, I try and remember why I'm doing the study and trying to keep it simple. I'm not asking you to tell us whether the ejection fraction is 36 or 37%. I'm asking you to tell us whether you think the left ventricle is bigger than 6 centimeters, in which case it would be dilated. Do you think its function is normal? And normal means that it kind of decreases that area up by about 50%. Or does it look like a paper bag floating in the ocean? So is that LV normal in size or function? And the questions are normally just yes or no. Does it look normal in size? Yes. Does it look normal in function? No. If it's not normal in function, is it severely abnormal or only mildly abnormal? I just try and keep these kind of big questions and keep it nice and simple. I'll ask the same question for the right ventricle. I'm not going to forget to rule out signs of significant hypovolemia, which can come from vasoplegia as well, and make sure we're not missing things like a tamponade. My final bit is I try to keep it clinically relevant. Do those echo features, they tie back into that clinical story. Like our guy that we had who was collapsed at home, completely shut down, hypoglycemic, that sign of that really bad left ventricle function was clearly contributing to that. Do we have any signs that might tell us whether we've got a chronic or acute feature? Things on the right ventricle, if you've got a really big thickened wall and lots of heavy trabeculation, that may say that you've got some chronic RV dysfunction as opposed to acute. Does it match with the past medical history? And that's where it's important to make sure you're taking history and integrating it with your echo features. Are you going to use it to help guide our fluid management, as we spoke about? Does this patient look like they're tolerating fluids if they've got a small collapsing IVC, a small right ventricle, small hyperfunctioning left ventricle? Those are all signs that that patient will tolerate fluid and will be fluid responsive, as opposed to our first case there where they had a big dilated IVC and a big dilated right ventricle. Okay, so I just try and tie it all together, keeping it clinically relevant. So is there any other evidence that this kind of works? Well, the answer is yeah, there is. This is another one of my favorite studies that came out a couple of years ago, which where they did a multi-center study in EDs all across the United Kingdom. They did into like 178 emergency departments for 1 week, and they got them looking at echo and patients who were in shock. And what they found is that echo, while it didn't improve outcomes, which I think is understandable, what it did do is it improved diagnostic certainty, and it helped people manage sick patients. And that makes a lot of sense to me. Sometimes I find I'm not the most confident clinician just with clinical examination alone. But when I've got my clinical examination and I do an echo, it often gives me a lot more strength that I'm on the right path. For example, if you've got a patient who's super cold peripherally and they've, hypotensive, they've got high lactates, poor cap refill, I might think that they've got a bad left ventricle function. But I'm much more certain of that when I can see it on an echo. And I think that's really useful that even if I'd be on the right track and it might not change my management, being more certain in my diagnosis is really, really important for me. Let me try another case. So this was a case of a 50-year-old woman who had some nasty chest pain with some fevers and was hypotensive. She's got a history of having a ST elevation myocardial infarction 4 years earlier, and she was thrombolized for that. She's also had a minor stroke with no major deficits and some type 2 diabetes. So let's have a look through our point of care pictures that we've got. Again, our left ventricle looks very abnormal. You can see down here, you can count up the centimeters, and the centimeters make it look like it's over 6 centimeters. So there's a dilated left ventricle. The function is not normal. Normal function, again, it comes back down, the left ventricle shortens down by at least 50%, and this one's not doing that at all. What I'm going to ask you to start having a look at is comparing the septal wall that we've got at the top here with the lateral wall that we've got down here at the bottom. And those two walls correspond to that wall that's up at the top in our uh, parasternal short axis and the one on the opposite side. So it's like what we call the anteroseptal, the anterior part of the septum, and the infralateral, the inferior part of the lateral wall on the other side. And what I think we're starting to see is that this one here on this side looks really thin and it's not moving, it's not thickening at all. And the one on the other side is not thickening brilliantly, but it seems to be doing a lot more than what it was doing on that side. And maybe that's starting to say that maybe we can think that we've got some regional wall motion abnormalities. And this is particularly what maybe an old heart attack looks like, is where we've got this thinned wall. So even though this lady's got some chest pain, we've got to be careful we don't say that it's an acute sign of a heart attack on an echo alone. We need lots more information to try and help diagnose it. But she's hypotensive. She was cool peripherally. She was peripherally shut down. What this can help direct us to then is what we were talking about just a minute ago, which is cardiogenic shock. This patient's got a terrible left ventricle function. They're shut down peripherally. They're cool peripherally. This could be pointing towards a cardiogenic component to this lady's shock. Does it rule out infection? No, you're going to need to do other things to try and assess with it. But we know that this patient is probably not going to be tolerating fluids very well. And that's where we can start to have a look at the other side. So looking at the right side of the heart, the right ventricle here in this subcostal view looks like it's working okay, but look at that IVC. We've got a big dilated IVC, which tells us we've got a raised right atrial pressure. We've got to be careful about overloading this patient if we give them too much fluid, okay? The IVC is not a perfect way of diagnosing congestion. I'm just saying you've got to be careful, all right? So what do we find from this echo? Well, we've got probably some signs of chronic ischemia in this patient. We've got that big dilated left ventricle, which isn't functioning well. And we've probably got, therefore, a chronic component going on. That chronic component means that you're going to have this raised pressure inside the heart, and that's likely going to dilate our left atrium. We didn't get great pictures of the left atrium in this study, unfortunately. But my guess is that this patient, thinking about that IVC dilation as well, that patient's not going to tolerate fluid well. And this is a patient who's going to need some form of a medication, and ideally an inotrope like adrenaline if we could get it. And noradrenaline, just got to be careful you don't give them too much. In terms of those regional wall motion abnormalities, that anteroseptal area looked thinned, it looked bright and akinetic. And that's pointing towards it likely being a chronic component. That lateral wall, though, looked a lot thicker and it wasn't moving as well. Could that be an acute process? Well, maybe, but you need a little bit more information. And that means that we've got to be going to look at ECGs, troponins if we can get them, and thinking about cardiology review and seeing if we can treat it other ways. Okay? So that's why we're looking at this patient. We can start to try and get as much information out of these relatively simple studies as we can. And we can say this patient's probably maybe got some acute, but it's on the background of some chronic changes. We're probably intolerant of fluids. This is not going to be this gentleman's friend. And we need to go looking for signs of ischemia and making sure we're not missing other diagnoses like sepsis, for example. Okay. Again, please interrupt me if you've got any questions. So when I'm talking about regional wall motion abnormalities, it's sort of this next stage of thinking about point of care ultrasound. We've got three main blood vessels around the heart. You've got your left anterior descending artery that supplies the front part of the heart and the apex. And we can see that in our parasternal long and parasternal short. It's this yellow segments at the front and at the top in your apical forechamber. If you rotate your probe just 60 degrees anti-clockwise, you can get your two-chamber wall. And here you can see this whole of this anterior section is supplied by your LAD territory. The LAD comes off your left main, and the LAD goes straight down towards the tip of the left ventricle, and your left circumflex comes off, and that looks after the side of that lateral wall of the left ventricle. And you see that here in the short axis. And it's the back part of your parasternal long axis. And it's the lateral wall on that apical four-chamber view. Now, these can have some overlap, and that's where you can see us sort of colored in these sections with a bit of yellow, bit of blue. And that's because there is overlap, of course, particularly if you've got chronic changes going on. But it's just a guess. I'm just sort of trying to show that there is a general pattern from that LAD versus that circumflex. And then the last coronary artery is the one that comes off your right coronary cusp of your aortic valve, and that supplies your right ventricle and the inferior part of your heart, and that inferior wall that we can see in this two-chamber and four-chamber there. Okay, so when we're looking at regional wall motion abnormalities, it's really unusual to get kind of patchy changes. They normally stick to a coronary artery territory. So just try and remember these patterns and see if they match with what you're looking at on your echo. This is another way to kind of think about it. It's just all done in one diagram. I'm imagining I'm looking up at the ventricle. If I imagine I'm sort of standing outside looking up towards the heart. So this is the apex of the heart, and this is the base of the heart. And we often talk about there being like 16 segments of a left ventricle, if you've ever heard that before. And again, as I look sort of up towards the heart with the apex there and the base of the heart there, that left anterior descending, it looks after that sort of top part of the heart, bit of the side. Your circumflex artery looks after the side part or the lateral wall of the ventricle. And then the right coronary looks after that right side of the heart and underneath. Okay, just two ways of showing the same kind of idea. When we're looking at regional walls, I'm going to talk about it whether they're thickening normally, which is greater than 50%, whether they're hypokinetic, which means they thicken but less than 50%. I think that's what that lateral wall was doing in that case. Or they're not thickening at all and they're akinetic. And that typically happens when the whole myocardium is either completely stunned or has died. And then the last part is dyskinetic, means that it doesn't thicken, but it moves outwards during systole. And so we can try and describe these walls as accurately as we can using those models and those classifications. So I'll show you a couple of examples. So if we look at this one, this is a two-chamber view. So that means you've got your anterior wall here on the right, inferior wall on the left. And just try and have a look about how these basal segments of your basal inferior and basal anterior segments, look how they move differently between these mid-ventricle and apical segments. And here they look like they're akinetic. They're not thickening at all. You can see how these ones thicken by more than 50%, those basal sections, and the rest of them are just fixed. I try and have a look sometimes for what I call hinge points. I can almost see that there's an area right there by that sort of R of the inferior where the bottom part looks like it's moving and the top part just moves like it's rocking. And that's a hinge point, and that can tell you you've got a regional wall motion abnormality. It can sort of just cling your eye into it. And this is an example of someone who's got LAD territory infarction. Okay. How about this one? So here we can see we've got the a short axis view. So it's the anterior wall on this right side here. Got our right ventricle here. There's your septum. So there's your inferior and anterior walls, and this is the lateral segments. And I use it like a clock face. I just compare one side to the other. So I might look at these septal segments and compare them to the lateral wall. And what I hope you can start seeing is that these sections thicken more than 50%, as opposed to this side, which is thickening way less than 50%. So this side, that lateral wall, has some significant regional wall motion abnormalities and hypokinesis. So what coronary artery supplies that area? LAD, circ, or RCA? Well, it's probably B, it's the circumflex, okay? Because that circumflex covers that area on the side here. LAD territory does the top, and right coronary does the other side. Okay, so it's just about pattern recognition and trying to use all the images you can. Okay, last one to do is let's just jump in and talk a little bit about some of the others. We spoke about sort of some distributive shock from sepsis. We've spoken about some cardiogenic as long as some hypovolemic. And let's just show you a little bit more about that. Okay, so hypovolemia is where we say a patient is definitely going to be fluid responsive. And this is what it might look like, where we can see we've got a small left ventricle, we've got a high heart rate, and we've got a ventricle that looks like it's got that kissing ventricle signs. Those two ventricle walls come together at the end of systole. Now, you need to make sure that we're on axis. So you're going to look at other windows, and I particularly use the short axis view to try and help tell me that I'm not sort of haven't been imaging it badly and I'm not sort of off to one side. And here you can see there's obliteration of that end systolic cavity. It's just there's no inside of the sort of left ventricle left at the end of contraction, at the end of systole. And it's that obliteration of the end systolic cavity. And you can see it here in your apical view as well. And then look at the IVC. The IVC is completely collapsed, small. You've got a low right atrial pressure. So this might be an echo features that would suggest hypovolemia. There'll be lots of clinical features as well, and this might just back up your confidence in giving this patient some fluid. And we might give them 1-2 liters. We're going to watch the IVC. We're going to look at that right ventricle, look at the size of the left ventricle as we give fluid, and see, you can see all those changes real time as you give patients treatment. Come back a couple of minutes later, scan them again, and you'll see the effects of your resuscitation. So let's have a look at case number 3, okay? So case number 3 is a 65-year-old guy had some form of mediastinal mass that was giving him some airway obstruction. He was intubated. As he was starting to wake up, we saw this rapid escalation of vasopressors in this guy. And echo was really useful in trying to help diagnose what was going on with him. So what we can see as this guy was waking up is, first of all, that there's signs of there's rapid escalation of catecholamines. And can you see these echo features of, what do you think of the left ventricle? Well, first of all, it looks very small, doesn't it? You can see the centimeter markers down the left here, and that ventricle at its maximum is probably only 3 centimeters wide. And when it contracts down all the way. Okay, we've got a kissing ventricle sign. And so we might suggest that these are signs of hypovolemia. I've got a bit of color Doppler on here. And again, I know not everyone's using color Doppler yet, but what I encourage you to have a look at is, can you see this bright yellow marker that comes through? Now, in color Doppler, you can see this marker along the edge of the image that shows that it's using color Doppler. And the faster something goes, the further it goes up the scale. And you've got red means that flows are coming towards you, and blue means the flows are coming away. And the faster they get, the more they turn lighter colors. And what we can see as we come through here is there's loads of light color coming through. Okay. One of the other things we can do is, if we pause the image, we can see it here when it's filled up. That's it, end diastole. It can help if we've got the ECG, but sometimes you can just do it looking at the mitral valve. But then look what happens as we get down to systole. Systole, we can see that there's part of this mitral valve that's being pulled in towards that LVOT. And that's a sign of systolic anterior motion of the mitral valve being pulled into that left ventricle outflow tract. And that's what's known as SAM, systolic anterior motion of the mitral valve. We can see it in other views here from an apical 4-chamber view. You can see that anterior mitral valve during systole gets pulled into the left ventricle outflow tract, and we get this highly chaotic, lots and lots of yellows and light blue flows coming through that left ventricle outflow tract. And this is probably what's happened, is this guy's hypovolemic. He's getting a Venturi effect. It's pulling in that mitral valve in towards the LVOT, and that's what's leading to this super fast escalation of catecholamines. M mode, if you can remember, some of this stuff can be used, and M mode can show you where during systole, when the mitral valve should be shut, what we can see is that during systole, the mitral valve is being pulled in towards the LVOT. Now, these are quite advanced features. I hope it's okay to show you these, because it's an unusual cause of obstruction. But it was done by a trainee in Fiji. I think the lady who is actually in charge of the unit, called Nisi, Nisi's getting pretty good at echo, and she's starting to use Doppler. And she was able to pick up, with the help of Lewis, one of the Pearl's instructors, to pick up this LVOT obstruction. And that was linked in with the clinical features of this rapid escalation of vasopressors. And what that means is that we've got to do everything we can to fill this patient up. We've got to avoid giving them a whole bunch more of the vasopressors. And we need to stop that and give them a lot more fluid and try and slow their heart rate down. We can use other things. Other forms of Doppler are available. Pulse wave Doppler. where we can have a look at flows in different parts of the ventricle, and we can start to see these late peaking jets, which is how we actually diagnose systolic anterior motion. Now, you might not have all of these features on your pointed care ultrasound machines, but again, just to show you what's possible out there and how useful echo can be in personalizing your shock management, because it really helped looking after this patient to stop increasing the vasopressors and go higher and higher and higher because they were becoming more and more hypotensive. And what we actually needed to do was give this patient a lot more fluids, and we needed to give it to them very quickly. Okay. Another really nice paper from a French group that shows that if we miss this kind of stuff, if we miss hypovolemia and we miss some of the LV obstruction from that kissing ventricle sign with echo, if we miss that, the mortality is far greater. I think that makes sense to us, right? You know, if we under resuscitate our patients, and on the flip side, also if we uh, over if we give them too much fluid, we know that both of those things are associated with worse outcomes. The mortality in patients that were found to be sort of hypovolemic, their mortality was actually almost double compared to those that weren't. Okay, the last one I'll just show you about an obstructive cause. I said right at the beginning, we need to make sure we don't miss these kind of things. And all I can say is I sometimes find these challenging. And this is a great case from Lewis. Oh, sorry, not this case. Sorry, this case was from Vanuatu. This is another form of obstruction that we'll see, and I imagine you guys see it a lot more than I do, which is someone who's 40 years old, known to have rheumatic heart disease, and became breathless and hypotensive with a fever. And what we can see here is this in this parasternal long axis view, this huge left atrium, and look at the mitral valve. This is a sign of a mitral valve with this very thickened edges. The mitral valve doesn't open like it normally does with a sort of a flapping effect. It's stuck together, and it's stuck together because the ends of the mitral valve are so thickened. And this is a sign, which you can see on the right here, of that hockey stick appearance, they call it, which is where we've got signs of significant mitral stenosis. And that's leading to a huge left atrium. And that's raising up your left atrial pressure. And you can start to see those B lines from pulmonary edema coming through. If you do get a chance to put the color on it, you can see what we call this candle flame appearance, super aggressive, rapid blood flow coming through because you've got such a small mitral valve orifice. And you see here that the mitral valves are basically just stuck together. It doesn't open up at all. It's leading to lots of signs of congestion. You can see pleural effusions, a bit of ascites, a big dilated IVC. And look at these pleural effusions. Lung ultrasound is really easy. If you've got your echo probe, just slide it around where you put your stethoscope. We see here a lung that's squished down because there's so much fluid, which is this black fluid around it. And so that, with the edema and the raised left atrial pressure, was causing the patient to become so hypotensive. And that could help direct us to this idea that this patient does not need fluids. The hypotension need to probably be looking at trying to drain these effusions, diuresing this patient, and trying to figure out a way to stabilize things as much as you can, because unfortunately, without some form of breaking open of that mitral valve, this patient will find it very, very difficult to survive. Okay, so it's likely looking at some form of end-stage disease, unfortunately, in this gentleman. He's obviously not fluid tolerant. You need to diurese this patient, try and remove what you can of the fluid in the body, try and avoid increasing up any pressures on the heart, and probably not for intubation. So the final case I'll show you, which was absolutely fascinating, and this one was from Fiji, and this is Lewis's case. They were um, short and hypertensive, and the team were working very hard. He was on lots of support. He was just died. Excuse me. And what they found is this guy may have some having HIV. And what they found is that this gentleman had a
pericardial effusion surrounding the heart, but they were looking for echo features of tamponade, and they're sometimes quite tricky to look for. We're looking for those signs of wall collapse, particularly of your right atrium and right ventricle. And so you look at it in multiple different angles as best you can. And what we thought we might be able to see here is some form of right ventricle collapse, but it was subtle. And what was really useful was using Doppler, looking at pulse wave Doppler, looking at flows through the ventricle, and you saw these big swings in blood flow through the heart. There was maybe a little bit of sign of right atrial collapse that we can see here, but it's subtle. And there's also some right ventricle collapse at the top here, which is subtle. And again, it just reminds me that it's not always easy trying to diagnose tamponade with echo. But this patient was really short of breath. It was worse than they were lying down flat, and they were hypotensive. This led the team to try and have a look at the heart from lots of different angles. And this is a really nice example of using the subcostal view, but looking at it with a short axis. So if you can see the IVC, just fan your probe over towards the patient's left, and here you can get a short axis view. And again, I think this showed with a little bit of better characterization that that right ventricle free wall was collapsing there, and that was during diastole. Big dilated IVC, and all of this led to the idea that we are dealing with tamponade in this gentleman. But the main features that were pointing us there was the fact that he was short of breath, hypotensive. There was a bit of argument about whether or not to drain this effusion. And at the end of the day, stick with this idea that tamponade is a clinical diagnosis and echo just supports it. And this gentleman had his effusion drained and the hypotension and shortness of breath got better. And he did a great job. Okay. So that final take home message is that tamponade is a clinical diagnosis. Okay. And it's just backed up by echo. I really hope that was useful. I hope, clinical examples of all the different types of shock, particularly this idea that to use a kind of different ways of thinking of the shock from that left ventricle arterial coupling, that microcirculation coupling, looking at fluid congestion and making sure your patient's not fluid intolerant, and don't forget about the right heart. Try and keep that integrating all those echo features with signs of shock and recognizing it early and doing this repeated analysis to try to see if your assessment is working. And please do reach out if there's any help or anything we can do. And I just really hope you got something out of that talk. And thank you very, very much for listening.
Thank you so much, Sam. That was amazing. I really liked how you made it quite simple and quite, I don't know, I feel like my kind of understanding of Echo was just kind of, oh, look at all these different things, but I couldn't really piece it together how it changes what I'm going to do. But you kind of put it as like, look at the right ventricle, is it dilated, how's its function, and then based off that, you can discuss about fluids and fluid responsiveness and whether you should withhold or consider obstruction. So I liked the kind of breakdown.
I'm really glad to hear that because it's meant to try and keep it clinically relevant. I think it's
Mm,
so easy to go down a bit of a rabbit hole with echo and, trying to make every view absolutely perfect and getting sometimes, lots of things are happening and just trying to have a bit of a framework to work on, not trying to sort of leap too far ahead and
mm,
just trying making the best assessment you can of that cardiovascular system, try something and then reassess. And
mm,
if you can link your echo with your clinical sort of appraisal of the patient, you can start figuring out if what you're doing is working or not. And trying to
mm,
keep these scans fast and clinically relevant, I think, is the key. And certainly that's how I try and practice.
absolutely. Okay, so we'll move on to Q&A now. So we'll stop the recording.